Let me introduce you to our speaker today, Dr. Judy Garber. She's a distinguished oncologist and prominent researcher who currently serves as a Susan F. Smith Chair and Chief of the Division of Cancer Genetics and Prevention at Dana-Farber Cancer Institute in Boston, and she is also a professor of medicine at Harvard Medical School. Dr. Garber conducts research in clinical cancer genetics.
Send you the short form. That's enough. It's enough.
Okay.
You don't need all the rest of this.
Okay. And now I introduce to you Dr. Garber. If you want to know more, it's
Written down. Thank you. So we can try this without questions, but it's okay to have questions, I think. And I'm going to try to talk about several projects, studies that are going on in chemoprevention or prevention for breast cancer, and we will talk about vaccines, none of which are active, but all of which are close. So we'll try to make this work. Okay. So actually, in scientific circles, cancer prevention has changed its name to cancer interception. And it's understandable, really. You know, there's the formal definition was proposed by Liz Blackburn, who won the Nobel Prize, so we pay attention. She called it the active way of combating cancer and carcinogenesis, or cancer development, at earlier and earlier stages. And that's important. Obviously, the reason we stopped using prevention was because prevention felt like it was permanent. You could prevent something, it was never going to happen, and we couldn't really promise that. So interception has become the scientific word. You can definitely substitute them in your head when you hear people talk about them, but that's the reason. And you can think of colon polyps as a paradigm for this, where colon polyps are, adenomatous polyps anyway, are the ones that are going to become cancer if you take them out. Then they don't become cancer. You have intercepted them before they became malignant. We're talking about breast cancer, so we're really talking about things like atypical hyperplasia maybe, or DCIS, ductal carcinoma in situ. If you leave it, it will become malignant. But the problem with this, of course, is you have to know how to identify these early steps and then know how to interfere. So here's sort of a way of thinking about this. And this is a slide Susan Domchek loaned me from her recent review in Cancer Discovery, which is a big high-impact journal. So what you're looking at here, I hope this works, more or less. Yes, well, over on the end, so this laser is pointing, but I'm not sure you could, there you go, sort of. There's BRCA, and it's plus minus. So plus is the symbol, if you've seen it during the conference, right, for the sort of normal sequence, the wild type. Minus is something having a mutation. So here, or a variant. Here we're talking about cells in someone who was born with a BRCA variant or mutation, depends on where you are in your language these days. In the next box, this is not going to work. This one, minus minus. So minus minus would be that you've lost the normal sequence of the BRCA1 gene. That cell doesn't have a normal copy of BRCA1. And we talk about that as an important step to cancer development. The tumors generally don't have any functioning BRCA1 in someone who has a BRCA1 mutation. If it's BRCA2, the tumor will have lost the healthy copy of BRCA2. Now, it doesn't kill the cell to lose that. It lets the cell grow. In fact, it lets the cell grow unregulated, because remember, these genes are part of fixing errors in the DNA, and you'd think that if they weren't working, you would just continue to accumulate more and more errors, and you do. And sometimes that makes cells that can't function, they die of their own, they're sort of suicidal. But sometimes you make cells that just become more and more independent and acquire more and more mutations and more new abilities, and those are cancer cells. So what you see in this diagram is that the question is that the first thing that happens for a cancer to develop, that you lose that normal copy of BRCA1? And it's not clear whether it's first, although it's clearly early, but then other things happen, and you get abnormal cells, and then early stage cancers like breast cancer, and then metastatic disease. So obviously for the interception part of this, you'd like it to be on the early side. You don't have to do anything to the normal cells. They're fine, but it's the ones that have started to change that you want to interfere with. So the problem is that most drug development is about treating tumors that have already become established, that exist. And that's easier. You can characterize the tumor, you can find the mutations. What we want to do is on the other side, and we want to take the progress that's been made in the targeted therapies that you've been hearing about at this meeting, and we'll talk about PARP inhibitors, and back them up to the prevention or interception part of this. So besides the terrible name chemoprevention, I don't know who thought of this, why don't people take medication to prevent breast cancer? So what do people do? You know, in this world where we live with high-risk alleles like BRCA1 or 2, it is an established fact that removing the breast tissue will prevent breast cancer development, mostly permanently, but at least reduce breast cancer risk. In other genes like ATM or CHEK2 or others that have been mentioned at the conference, CDH1, P10, these are not as much risk. Surgery isn't always recommended. TP53, yes. Some of these others where the risk is not so high, maybe surgery is not the way. So then what can we do? Well, now we're talking about interference, interception, ways that not surgery. We would like to have things, at least letting everybody delay surgery, maybe, you know, during those younger years when surgery's even harder to face. So people thought about chemoprevention, which I am really sorry everybody hates the name, but it's just meant to be medication to help, or agents or drugs, and they don't have to be drugs. You can have chemoprevention with natural products as long as they work. So why don't people do this? So remember, the poster child for breast cancer prevention is tamoxifen. And tamoxifen, which was studied in the 1990s, was shown to be very effective in reducing breast cancer risk, in preventing breast cancer, although maybe not preventing completely. The drug works very well, but people don't take it. Why don't they take it? Well, here's from a study that looked at this and said, because these things have side effects. People are not interested in side effects for prevention. That's totally understandable. Also, tamoxifen, even though it reduced the risk of breast cancer in the original studies by 50%, and for people who had a biopsy with a finding that was somewhere along that pathway closer to breast cancer, by 70%, you would think, sounds pretty good, take it for 5 years, and the preventive effects last 20 years. You can still show it. Why not take it? Well, because they had side effects, and in fact, people did not live longer. And maybe they didn't live longer because if they did get breast cancer, it was still detected early, they were being monitored, and they were cured. They didn't change survival. So is that good enough to just delay? And that's a question. And then the big problem we have on the prevention interception side of things is, where do we get the agents to study? So obviously for treatment, people work with pharmaceutical companies. They are very anxious to make drugs for treatment. If you went to any of the other treatment sessions at this meeting, you would have heard about immunotherapy in Lynch syndrome and PARP inhibitors in BRCA. Well, the drug companies tend to make money off this. Why aren't they interested in prevention? Because to them, it's kind of all liability. It's all risk. They're going to take healthy people and cause side effects or cause trouble. It's going to cost them. They're not interested. And the other thing, really, to be fair, although it's not on the slide, is that, you know, to use something for risk reduction in a healthy person, you have to have pretty good safety data. You want to know that this drug you have is not going to cause serious problems. And that means you have to study it for a while. It's not good enough to say, well, you know, in these studies that they do in advanced disease where people live months extra, so the study may take 5 years. That's not good enough. You want to know the drug's going to be safe in the long term. By that time, the drugs are no longer on patent, and the pharmaceutical companies then really don't make any money, so it's very hard for them to get interested in this. Now, I have to say, we are working with one to try to get a PARP inhibitor study into prevention. You'll see what you think. So we have had some success, but it's not the main thing. Okay, so you don't have to be able to see this, I hope, because there are a lot of trials on there. But this is just to say people have actually done a lot of trials for breast cancer risk reduction or breast cancer prevention because breast cancer is a common disease and because we knew that interfering with hormones would help lower breast cancer risk. That's fine for the general population where most of the breast cancers are hormone-driven. BRCA2, most of the breast cancers are hormone-driven. ATM, check 2. Most of these tumors, TP53. BRCA1, most of the tumors are not hormone-driven, and you wouldn't expect these hormones to make a difference. But these studies, which have been done around the world, and have established that drugs like tamoxifen or aromatase inhibitors, medications that are used for breast cancer treatment, actually prevent breast cancer. They reduce the risk of a new breast cancer in the opposite breast, and they reduce breast cancer risk overall. But they haven't become necessarily part of treatment, particularly for things like BRCA1 and 2, where other interventions affect hormones. So for example, having the ovaries removed makes a big effect on hormones. If you don't take hormone replacement, there's been a question about does this work? So there's been issues, but you shouldn't think that people don't try. It's just a question of, all of these are sort of variations on the same drugs in a good way, but not ideal. So this is also why have people not taken it? So what are the risk factors people use for these prevention trials? Chest wall radiation, like someone who had Hodgkin's disease and had radiation, they have an increased risk. Mutations on average, family history sometimes. These are the risk ranges we're talking about. Remember, the population risk of breast cancer lifetime is like 12%. So everybody here is higher. So the big change in prevention overall, and it's something for us to think about too for particular populations, came with this study, which is called Baby-TAM. So the tamoxifen studies were all done with 20 milligrams of tamoxifen, which was the amount that you took for treatment. And as I said before, the drug worked very well. People at high risk for family history or a biopsy, you could reduce the risk significantly, but nobody wanted to take it because it caused menopause symptoms and leg cramps, and also a small risk of uterine cancer and a small risk of blood clots. So this was not to be taken lightly, and in fact, many women wouldn't take it, and many physicians didn't want to prescribe it. So the Italians said, well, the full dose works, maybe a low dose would work too. Maybe not as much, but it might also have fewer side effects. So they did Baby-TAM. So full dose is 20 milligrams, this was 5. And they studied women who had higher risk of breast cancer, either because they had, as you can see all the way on the left, they had ductal carcinoma in situ, or they had one of these other findings on biopsy, and they randomized them. Half the women got the 5 milligrams of tamoxifen, the other half got the placebo. They treated them for 3 years, and then they did the follow-up, and they did this all in Italy. And what they showed was, so I don't know how many of these things you've looked at, but basically they showed that the tamoxifen group had a third as many cancers as the placebo group. So it reduced the risk by a third, which is not too bad for a quarter of the dose taken for about half the time. And in the second paper, the long-term follow-up paper, at 10 years, there was still an effect. So all good, and people actually take this. So this is really important because for a long time, people said, well, why do you even want to study prevention? Nobody's going to take the stuff you find works. But that's not true. If you make a drug that women can tolerate, they don't have unusual side effects, they feel well, and it works, people will take it. So that is a very important principle for thinking about these other things that I'm going to talk about today. So there are still some side effects, but they're actually kind of equal between the tamoxifen and the non-tamoxifen group. And that has led to another study that's about to start. It's run by the same investigator, Dr. DeCenzi, who was the Italian investigator with this. It's going to be done as a pilot study in Italy, in Boston, and at Columbia in New York. And this is asking about comparing Baby-TAM, the low-dose tamoxifen, to baby exemestane, so that's a different drug. And it's in women who are it's going to be called baby tears. Hopefully that's not a bad sign. But I circled in red the fact that it is for women who are at higher risk for their DCIS or their other biopsies, or for women who have higher risk because they have an ATM or a CHEK2 variant. Because we said it's time we got some genetics into these studies, and the risk for women who have those mutations is about the same as somebody who has risk from atypical hyperplasia, about 30%, right? So we'll see how this goes. It's not, so this is another problem with prevention studies. You know, to really show that something prevents, as we said, you have to follow everybody for a long time. But it's very hard to get studies where you can get paid to follow them for a long time, and you have to be definitive. So you have to do what we call phase 2 studies, shorter studies, at least to get a signal that you're in the right direction. And that's what this will be. So it's only a year of follow-up. Okay, so let's talk about, in the BRCA space, the BRCA-P study. So I don't know how many of you have seen this. I know it gets mentioned periodically. So up there in the corner, that's Jeff Lindeman. He is an investigator in Australia. So just so you know, this is a very international activity. So Jeff looked at cells that were developing into BRCA1 breast cancers and showed that one of the important molecules that was driving this development was a molecule called rank ligand. And if you gave a drug that blocked rank ligand, you could turn off the breast tissue. So that's what you're seeing. These are mice. So here, they're not recording the sound if I'm not here. So over there, that's a breast that's kind of on, right? So this is a slide of breast tissue, not a mammogram. This is just a piece like in the pathology department. And if you give something to block it, you can really turn it off. And there is a drug that blocks rank ligand, and that drug is denosumab, which is a drug that's used to treat bone loss, osteoporosis. But it blocks rank ligand. And you can see at the bottom those curves. I'll try again. Never mind. Here. That the black is the path of, in a mouse, time to breast cancer, mammary tumor or breast cancer development. And in blue is if they gave them a dose of this rank ligand inhibitor, denosumab, you could delay the development of tumor in the mice. So that has led, oh no, to an international study. Now there's some really weird something going on here because I can see this. Wait a second. Let's see. There you go. Oh, yes, to an international study comparing rank ligand inhibitor denosumab to placebo. That person circled in red, you know, that's Sue Friedman, and this is going to be like, where in the world is Sue? Like, where's Waldo? You will see Sue Friedman in her red circle reappear on many of these slides because she's often there advocating for research projects in BRCA carriers. So here's Sue. And there's Jeff Lindeman, who you just saw, and at the top is Christian Singer in Austria and me. So this is a randomized trial that's being done in 7 countries. You can see them all across. On the bottom is the United States map where the sites are that are doing the trial. It's actually been really hard to get women with BRCA1 mutations to be on the trial. And right now it's only BRCA1. That might change. But it's a definitive study. It's meant to ask, does this drug prevent breast cancer? But it's hard, I think, for women. First, there's a placebo arm. That might be an issue for some people, that they're not so sure they feel safe. Some people, when they finish their families, they want to have surgery. They don't want to deal with this stuff anymore. I think that's really an issue, too. Some people don't like drugs that have side effects, and you know there is no free lunch in all of this. So that's also true. But I think, you know, we're still trying. We've been at it for 5 years. And we actually get drug from Amgen. We have money to support this study from the Defense Department of all places, and from the Gray Foundation. I mean, this is the real thing. So I would say, you know, why would you go on a trial with a medication like this? You know, if you're ready for surgery, this is not for you. If you're still having children, this is not for you. But if you're thinking about surgery, but you're not planning to do it right away, you could go on this trial even if you didn't stay on for 5 years, just a few years, and we would still learn things that might help us figure out, is this something that could do what we asked before, intercept. I don't think this is permanent prevention, but if it works like tamoxifen and it buys you 10 years, might be worth it. So it is an injection, but it's an injection every 6 months, so not too bad. And you continue the mammogram and the MRI, all the usual stuff in between. Here's another, so I'm sorry about these sort of technical things, but you want to know, right? So I should tell you what's going on. So this is a combination called basidoxifene plus estrogen. It's called Duave. I don't know if anybody's heard of Duave. It's not that well known. Duave is a drug combination that was developed for hot flashes. So hot flashes are pretty miserable. You would like to give something for hot flashes. There's estrogen. You give estrogen for hot flashes, but they put it together with basidoxifene, which is a drug that actually blocks estrogen in some tissues. So the combination has some estrogen features and some prevention or some blocking features. And the drug is approved for hot flashes. It's been studied in thousands of women to make sure it was safe for healthy people. It has no adverse effects on the uterus where hormone replacement can. It's actually good for bone. They just didn't want to really know about the breast because it raised all these questions. Could it cause breast cancer? But they did do a study in monkeys. So in these monkeys, so on the left is CTL is control, so they got nothing. BZA is basidoxifene alone. On the left is the CE, that's estrogen by itself, and then in the right corner, that's the combination. So in the top, it's just mammary tissue, breast tissue in the monkeys doing its usual thing. On the right, the basidoxifene, it's blocking some effect in the estrogen, so it should look a little less pink than the one on the left. On the bottom corner, that's with estrogen. You can see that really turns everything on, so you can see all that estrogen. And then on the bottom is the combination, which you have to say doesn't look like estrogen. It looks like one of the other ones. It's a little better blocked. So it blocks estrogen in mammary tissue or in the monkeys. And the question is, how much are humans like monkeys for this drug? And so there is a study being done for women. It's headed by the University of Kansas. We call it the Crescent study, and it's looking at this drug combination for the short term in women with some increased risk. So again, women with not with BRCA mutations, with less powerful mutations like ATM and CHEK2 and other categories. And then for us, we have a study for BRCA2 this time, since the BRCA1 women were in the BRCA-P trial. And this is a study for women who were having their ovaries removed and would agree to take this medication for a while to see, first, does it help their hot flashes? And would we be able to look at whether there's a change in their breast tissue by mammogram, where you can show that things are less intense? So, you know, these are baby steps for prevention, but we got to start somewhere. And so this is a study to try to get, you know, they're going to have symptoms after their ovaries are out. We got to try something. Maybe this will be safe hormone replacement because it has a piece that blocks the effect on the breast. Okay, so let's talk about PARP inhibitors. So how many of you have had enough about PARP inhibitors in this conference? You've already heard. So I'm going to take that as a yes, I can talk about it a little bit. Okay, so PARP inhibitors are very interesting drugs that they showed us, I think, a picture of Andy Tutt at one of these that Sue had in one of her talks. They were developed by a group in the UK with the idea that you knew what BRCA1 and 2 were doing. These drugs could add to the fire. So BRCA1 and 2, we said that these are important drugs in repairing errors in the DNA. So cells are dividing all the time, and sometimes they make mistakes, and your body has 5 specific pathways to fix errors when they occur. Because it's really important that you not make mistakes all the time. Although, of course, your bodies make mistakes all the time because cancer is a very common disease. And it's not clear why BRCA1 and 2 are important in the tissues they are, right? Breast, ovary, pancreas, prostate. Why not everything else? You've got BRCA1 and 2 and everything else too. Well, nobody knows the answer to that yet. But here, what happened was that if you had cells that were already not perfect in their DNA repair because one of their BRCA genes was not working, and you came in with a second hit against that DNA repair, now the cells would die. And that's what synthetic lethality means. And here's the diagram for this. So if you have normal cells with a table with 4 legs, in a BRCA carrier, you've only really got 3 legs. And then comes the second hit, it's DNA repair, it's these PARP inhibitors. Now you're missing 2 legs the table can't stand. So these are the tumor cells. They have a missing piece, they lose the second hit, you can't fix them. So that's what PARP inhibitors were supposed to do, and I'm sure that really didn't make any sense to most of you. But what I will say here is when they tried to look at this, so remember with the plus-minus notation we learned, this is a slide for BRCA1 and BRCA2. The top curve, the one that looks like a sort of falling off the waterfall, that's for the BRCA2 and BRCA1 plus. Normal cells, no mutations, they don't care about the PARP inhibitor, nothing happens. At the bottom, the red, that's minus. This is the tumor, has no functioning BRCA1 or 2. Those are killed. And in between are actually closer to normal are the plus-minus cells. All the rest of the normal cells in the body, they're fine. It's not till you have that tumor that the PARP inhibitor can work. So the nice thing about PARP inhibitors were they're not supposed to bother your normal cells, just the tumor cells. So we've spent years studying lots of things about them. One of the first things that was done was by Jas Jankers, who's a guy in the Netherlands who had these mice that he made BRCA2 mutated. He took out one of their BRCA2 genes, so then they were like people who had a BRCA mutation. And he gave them a PARP inhibitor, and what he saw was that they did develop mammary tumors or breast tumors, but a lot more slowly. So he couldn't turn it off permanently the way he gave it, but he could at least show that they could delay the tumor development. So this was promising, not good enough, but a good beginning, because until then we had nothing that did that at all. And this is just a treatment trial just to show that giving a PARP inhibitor, olaparib in this case, to women with breast cancer and a BRCA1 or 2 mutation, that women did better. These don't look like huge differences, but women lived longer because they took that PARP inhibitor after their other breast cancer treatment. And among the important things we learned in that study was not just that they did better from their breast cancer, but also that they didn't have a lot of side effects. So PARP inhibitors are oral, they're a pill. So if you want to have a prevention agent, better than an injection, might be a pill that you could take. And the most important thing they didn't get was extra cancers like MDS or AML, like leukemia, damage to the blood cells, this was a worry, or lung cancers or extra cancers. And in fact, you wondered if you gave the PARP inhibitor, could you reduce the risk of other BRCA-related tumors like ovary or fallopian tubes or peritoneum? And you can see that the numbers are small, but the right side column has the bigger numbers. That's the placebo arm. The BRCA arm has fewer. Now, it's tough because, a lot of people had their cancer, then got their testing, then did the study, then got their ovaries out, right? So we're not necessarily going to have the natural experiment of what happens to the ovaries, but the other organs you can look at. So there's maybe a hopeful signal here that taking that drug to treat one cancer can reduce the risk of others. And this is the quality of life, one of the slides, asking how bad was it? So I told you tamoxifen, bad side effects, nobody wanted to take it. Here, PARP inhibitors, on the study, most people took their drug for the entire year after the study, and they measured all kinds of side effects, and it actually was pretty good. So if you were going to look for a medication for prevention, you might say, what about a PARP inhibitor? You might say, what, are you kidding? You're using this for treatment? Would you use it for prevention? So this is the question. Could you think differently about prevention or interception? And Susan Domchek and I have been working on this for a long time with the idea, not that tamoxifen, these drugs you take every day for 5 years to try to lower breast cancer risk. That's me, I'm sorry. What if you could just go in and knock out those cells that had started to transform, that were just on their way to becoming cancer? Get rid of them, reset the clock, do it again later. How much later? That's a big question. This was a nice model Susan made. Every 15 years? Sure. What if it was once a year? What if you had to take, we're just going to ignore that. What if you had to take the drug for 3 weeks once a year? Maybe, if the side effects weren't too bad. Or 2 weeks every 6 months, I don't know. We don't know for sure, but this was the concept, that you might be able to take the drug and knock out cells that were starting to transform and then forget about it the rest of the time. So that was one of the questions. Could we use this PARP inhibitor for prevention if the idea was to give it for a short amount of time? So we looked at all of those side effects I told you about, and we actually have a trial that is going to the FDA. We'll see if they agree. So what this shows is, on the left, Susan Domchek, and me and Nadine Tung and Leif Ellison. We're all in Boston, as it turns out, except Susan. And the famous Waldo Sue Friedman, without whom nobody does any trials. And then the central group are the guys who are working in the lab. And the way this study is probably going to be done, and AstraZeneca is going to give us the drug, we think, is to have women who are going to have their prophylactic mastectomies. So people who know they're going to surgery, who might be willing to take the medication for a few weeks before surgery, so that we can collect the tissue from surgery and look at whether it's changing compared to people who have surgery and don't take any medication. We call these window trials, and you'll see a lot of studies like this where it's a short exposure. Now, am I sure this is going to work? No, that's why you do the trial. But it seems like it might be a way that we could use a medication that's been active and reasonably safe. Reasonably safe. I mean, I understand these were cancer patients. We all treat them. But could we do that? So that's what this is looking at, 3 different doses, trying to get to the lowest dose possible that has the effect on the tissue, and then compared to people who didn't take medication at all. And either that's people who said thanks but no thanks, or people that we've done surgery on before where we collect the tissue to study. So we'll see what happens with this. This is the first time that we've tried to do a study like this. There's also thought that this might work we could do the same kind of study in prostate cancer, where you have a chance of getting tissue. You probably can't really do this in ovary right now because there's no way to get that tissue. So I don't know what you all think of this. You could raise your hand if you think this is insane, but I will tell you that we actually thought of this 10 years ago. We got money to do this from the Komen Foundation, but the FDA said there's not enough safety data, and they were right, of course. But now there are these trials with much more safety data, so we'll see. Okay, so what about the immune stuff? So you all came to learn about vaccines, and I will tell you, vaccines, I don't know if you made it to any of the Lynch syndrome immunotherapy talks. Unbelievable effect of immune therapies. Not so strong in breast cancer, although standard of care for triple-negative disease, including women with mutations. But one of the issues is in the treatment of cancers with immune therapies is that they work much better when the tumor is present. So what you hear is that we give immune treatment before surgery, and then they do the surgery, and then you may give some after. But you give it while the tumor's in place so the body can have a target to fight against. And that seems to work better, especially in breast cancer, than having surgery first and getting the immune treatment after. That's a problem for vaccines, because what are you going to be immune against? And how are we going to make sure that these work? So you have to think about this a little bit differently. And I will tell you that, the world is like tripping over itself doing immune therapies in every cancer, and they work in an amazing number of cancers. Who ever thought immune treatment would work in lung cancer, bladder cancer, places like this? Not as good in breast, but still, more active in ovary and endometrium, so they're getting there. But the cancer vaccines are challenging, and you will hear about cancer vaccines as treatment, and that's because of this idea that the tumors make these molecular targets or proteins that are made by the tumor that the body, with a little help, can fight against. So treatment vaccines are one thing. We're going to talk about prevention vaccines because we're still going to try. So the question is, where are we already using vaccines for treatment, for prevention in cancer? Cervical cancer, HPV, anal cancer, oral cancer. We've heard about that this morning. There was a talk that talked about research progress. The vaccines against HPV are transformative. They absolutely prevent cancer. This is a virally caused cancer. Vaccine is a great way to go. This is not a virally caused breast cancer, so this is going to be a little harder, but there is at least precedent. So the University of Pennsylvania has been doing a study, and I'm not going to do a lot of detail with this first because I am personally not an immunologist, but just to give you a taste of where people are trying to go on the prevention front. So HTERT is a subunit of a telomerase. Telomerase turns out to be an important enzyme that works at the end of the chromosome, that blue part at the end. So as you get older, the ends of your chromosomes get shorter. This is just some other part of aging. But you can try to control that. They are targeting these HTERT molecules, and this is Dr. Domchek, Dr. Vonderheide at Penn. They have been trying them first in cancer patients. That makes sense, right? Most treatment trials, prevention trials will begin in treating patients with cancer. So first they did this in cancer patients just to show they were safe. And now they could show that they could measure changes in the immune system by giving these drugs. So immunogenic means that they made HTERT into something that the body could react against. And now they're doing their interception trial where they're taking healthy people with BRCA mutations who've agreed to come and have this vaccine where they use this little device and they scratch your skin and inject this stuff, and people have been willing to do this, so it's really helpful that the community is so dedicated. But so far, this is not to show that it prevents anything. It's just to show that you can turn the immune system on directly. So it's pretty early days, but at least they're starting. So I think this is very important. I'm not sure where it will go, but at least it's a beginning, and it's something the community clearly wants because people are willing to do it. And this is setting the risk. So here's Susan's diagram. So vaccines, the rank ligand inhibitor, denosumab, or PARP inhibitors. Maybe if you had some options, you could use different ones at different times. Okay. Dr. Finn, a second group, is at the University of Pittsburgh interested in trying to use vaccines to prevent breast cancer. Now, she's actually spent her life studying GI cancers and preventing GI cancers, but she's got a vaccine technology that seems to be interesting, and MUC1 is a molecule that's very prominent in the breast. So she's got this trial here where they're trying to develop the vaccine for prevention. So you can see at the top, vaccines come in treatment after you've got lots of disease. At the bottom is trying to move it earlier and earlier, trying to turn on your immune system. So I'm sorry about showing you more slides, but this is just different ways that the tissue begins to get activated. So their trial started in this ductal carcinoma in situ, and it's a randomized study. They're giving the purple, the aromatase inhibitor is a hormonal way of trying to lower risk. In the second, they've added the vaccine, and the goal is to see whether they can measure the effect of the vaccine. So Dr. Finn, who's loaned me these slides, tells me that the only problem they're having in the study is that people who get randomized to not get the vaccine are dropping out because everybody wants the vaccine, which is interesting. Not everybody wants the other kinds of vaccines, but for this, people are in. So we'll see what happens, but at least they're trying. I'm so happy to see this finally come. And the plan for the study right now does not include people with BRCA mutations. This is just all the different stuff they're going to measure. But the second step for this vaccine is to move to BRCA1 and 2 carriers. So this is a trial that will probably last another year till they get the number of people. And then if they're seeing what they expect to see, I suspect it would be BRCA2 because MUC1 is more common in that, in BRCA2 breast tissue. I can't tell you, I'm old. MUC1 was found at Dana-Farber by Don Keefe before I got there, and it spent all these years with people trying to figure out what to do with it. So it will be great if it turns out to be the right target for a vaccine. Who knows? But at least we have major immunologists and immunotherapists working on the targeting HTERT and now targeting MUC1. So then there is the group at the Mayo Clinic. So this is the Mayo Clinic team working on this vaccine, and down there at the bottom is Waldo, represented yet again, because as you can see, literally nobody does a study without Sue Friedman. So you should not worry that you're going to miss out. And this incredibly large team is working on a prevention vaccine for carriers. Now, Artemis is a vaccine that they're first starting to work on again in a broader group of women. And they have not yet gotten into humans, but they think they're about 2 months away. The protocol's under review. And the question is, they're going to try this otherwise, but at the bottom they also want to know, are there particular things they can target in BRCA carriers? So at the same time that the vaccine trials are going on, there's the biologic studies asking, what should we be targeting here? Is it BRCA1 or 2? So here is basically the trial. You can see on the left are all the things that their vaccine targets, and there are those familiar things like MUC1 and TERT, but also HER2, not that that's very common in BRCA carriers, or ATM, a little more common in TP53. Survivin, mammoglobin, these are all molecules that people have known are part of breast tissue for a long time, but they put them all together in a trial here, and they have 2 trials for safety. And then the right, the expanded cohort, that's where the BRCA tumors, where people with BRCA mutations will be enrolled on this trial once the first 2 show their safety and at least some activity. And they have funding from the Gray Foundation for that, so if you have funding, that makes it reality. But here's the original part of their proposal, and you see that this huge team working on this, so at least they're getting there. The first part will be safety, and can they measure the immune function all being turned off, and then the second part will be the addition of the BRCA carriers. So that's 3 vaccines not yet in BRCA, but all headed toward BRCA carriers. And these studies are early. They're not going to tell you for sure these work, but they're going to say, are we in the right direction? And which of these is the best? We'll see. So this is their hope that it will be active in prevention. And then the 4th prevention trial. So this is unbelievable. 4 vaccine trials aimed at prevention. And this is the trial that Tom Budd is running at the Cleveland Clinic. So we had Penn for the first one, right? Pittsburgh and a couple of other sites for the second. Mayo Clinic, actually really Mayo Clinic Jacksonville, but probably all the Mayo Clinic sites will have this. So that's Jacksonville, Rochester, Minnesota, and Arizona. So if you live near any of those, or are willing to travel when they're announced, this is the Cleveland Clinic. So here the idea is that your body has proteins that it makes at different times in your life, and then they stop. So you're just like, I love this example that we all had melanin. At some point now, we have chemical melanin. Maybe you don't, but I definitely do require hair dye to get to this state. But in this example, melanin is no longer being made by the hair follicles. And the question is, for some of these proteins that they say are retired proteins, can they now make them into targets for the immune system, since obviously they're not supposed to be doing much anymore? They have targeted a protein called alpha-lactalbumin, And this is a milk protein, so that makes sense. It's made in the breast. It's made in the breast ducts. We're not making milk anymore after completion of childbearing and lactation, so could they make a target against alpha-lactalbumin? And of course, there's been, for all these studies, there's been plenty of lab work trying to show that this is possible. Now, alpha-lactalbumin is expressed in human triple-negative breast cancers. Triple-negative breast cancers, we're back to BRCA1, so that's an important question. If you can see it in the tumors, is it going to be a good target here? So here are just their design of their study, 3 vaccinations, and then measuring all of this immune stuff, and then in the next study, they will put in prophylactic mastectomy. So this will be for the BRCA tumors that this study is doing triple-negative breast cancers and is going to add in BRCA1 prophylactic mastectomies, not requiring the tumors, but because that's what develops, doing like we are the window study vaccine and then collecting the tissue at surgery. So, and they want to do BRCA and PALB too. So, from my perspective, it's amazing that we finally have people working toward prevention, interception, that will hopefully be effective for breast cancer overall. That's fine, but these are actually targeting this community. And not all of them for BRCA1 and 2, but some also for some of the other genes that are a little less potent, but still give rise to tumors that maybe interception could be useful for. If you're interested in any of these studies, that I can give you information. If you're able to see the slides, I think you're supposed to have access to them. I asked everybody to include contact information for their trial. If there was a trial that you were interested in, if you can't find it, just contact me and I'll be happy to connect you. Some of these studies, it's too soon, but keep an eye out. And you know, FORCE always lists on the listserv the trials that are active. So BRCAP, the denosumab study, is on that list. I promise you when we get ready for the PARP inhibitor study, that will be on the list. And these vaccine studies, if they actually presumably make it to the next step, they'll be on the list. And we would all love to have it be that we don't have to be thinking about surgery anymore, or at least that we can put it off so that people don't have to do this before they're ready. And that is just because we always have to consider the risks and benefits in any decision. And there you are. So I'll take questions if anybody has questions at this point. Yeah, there you go. Good. Hi.
Thank you so much for everything you do. My question is, I mean, for me, it specifically pertains to BRCA, but are there different studies or different methods for targeting the different types, like triple negative versus whatever the other ones?
Yes, I mean, I think what I probably didn't transmit very well, but you know, the goal is to understand the biology of the tumor and then try to target that. So, you know, the problem to some extent, of course, is so BRCA1 tumors are mostly triple negative, 70%. But the other 30%, some of them are ER positive. There are HER2 positive tumors. It's opposite for BRCA2, but you know, so you don't want to miss, but you are looking certainly at which ones are you most likely to get. So you know, that's why these trials are like this. I think this morning there was a discussion of the SOROC study, which is an attempt to remove the fallopian tubes and see if you can prevent ovarian cancer. Well, why is it only BRCA1? Well, in that case, it's because the risk is much higher, and you hope you would get an answer that much sooner because the control arm things might happen. Here, it's really the biology. So it's understanding. You know, we have come, in that way, a long way. At least we know that for these other tumors, like the TP53 tumors, are 90% or more are hormone driven. Half of them are HER2 positive, half are HER2 negative, but there are hardly any triple negatives, which I have to say is a huge mystery because triple negative tumors always have TP53 mutations. They do, but that's not what people get who have these genes. So you can't predict what will be, you have to look. But yes, they try to make them specific. Yes, ma'am.
Thank you so much. This question is really about my 35-year-old daughter who inherited my BRCA1 mutation. She had no plans for any surgeries. She still was not married or children. So the question is, with everything that's available and everything, all the trials that are available,
Yep.
is specifically what should we be looking to do now, if anything at all, other than high surveillance?
So I would say, I don't know where she lives, but she could consider the denosumab study, the BRCA Peace trial, because so, there are, if anybody's here had their ovaries out and has had to use medication to try to protect your bones, there are two groups of medications. One are the bisphosphonates like Fosamax, Alendronate, the IV versions of these. The other is denosumab. And the Fosamax family, the bisphosphonate family, when you take those are permanently in the bone. So that is not a good idea before pregnancy. But denosumab is only temporary. So in 6 months, it's gone. So if she were to want to become pregnant, she could do that after denosumab. But otherwise, she should have careful surveillance. That's what we do for most people. We try to watch everybody and hope that we find some things early. And most of the data shows that we can. So close monitoring is still the standard of care. These are possibilities. Yes, ma'am.
Maybe I missed it earlier, but can you describe
Is that on, do you think? Okay, try again.
Sorry about that. Maybe I missed it earlier, but can you describe what a PARP inhibitor looks like?
As a pill, you mean? Or as a molecule?
Oh, I don't know if I heard it earlier,
Oh,
but
I'm
I
sorry.
thought it was some sort of implant or something.
Oh no, PARP inhibitors are pills. That's one of the nice things about them. All of the PARP inhibitors that you've heard about at this meeting, the ones for prostate cancer, ovary, but there are a bunch of different ones. In the beginning, they were intravenous, but now they're all available as pills. So it's not, so they're a little more accessible than some of the other kinds of medications.
Also, should these inhibitors prove successful in the trials, are they going to start recommending a minimum age to take them, like in your 20s?
So, I mean, this is a big question. So I would say, PARP inhibitors for prevention is the very beginning of a long journey. If we can show that they make changes in the tissue that are what we were hoping to see, that they actually look like there's less activity, then we have to ask, well, what if you take it, how long should you take them? When should you start? When is safe? I would say, drugs like PARP inhibitors that have the potential to have some serious side effects, I'm not sure I would want anybody to take them when they were too young. And remember, the risks are still, they're higher than the general population, but for the first 5 years, they're quite low. So people might not want to try it until 30, let's say, or 35, rather than 25. Now, everybody will decide for themselves. But the questions about when is the right time to do it, and should it be every 6 months or every year, all of that's going to take some more research to figure out. So trying to understand balance the safety against the activity, that's what we have to do. But at least we need a signal that we're in the right direction. And that's what this study is for.
Hello. So for the trials with the collection of tissue at a prophylactic mastectomy, would you need to have that surgery done at a participating research site, or would there be another way to collect the tissue from wherever you wanted to get that done?
That is a really good question. So generally for studies like this, So if you were, so this just in theory, so if you wanted to donate tissue for research, that can be done from many places, and many academic centers have ways to help collect the tissue. For a study like this, if you were willing to try the PARP inhibitor first, you would have to go to a place that was doing the study, because not just everyone would be allowed to give a drug as part of the study that gets approved by the government. So it would be usually a few sites, and the number of sites depends on how much money is available to support the study. So if you don't live in a place where this study is being done, for the first study, it's probably going to be restricted, but afterward, and some of these other studies like the BRCA-P study, that's open, in 35 sites in the U.S. So,
Just as a follow-up to that, could there be an option where you go to a participating site to receive the PARP inhibitor and then on
have
the
your
day when
surgery
you
at
go-
home?
Yeah.
Yes, you can. For this study, that is definitely possible. Also, remember, one arm of the study was not to take the PARP inhibitor, just to donate your tissue, and that you could certainly do, and we could figure out how to collect it. You have to collect the tissue for studies like this in a uniform way, so that that you're able to compare and not have the variation be some were handled this way, some was handled that way, but that can all be worked out. So yes, it's possible.
Hi,
Hi.
thank you for being here. My question is less about the things that are on the horizon and more about some of the preventative measures we've already studied, like the tamoxifen. We've been talking about doing it in 5 years and then stop, but some of the side effects are very menopause-like. Do those go away after you stop taking it?
Yes. So tamoxifen, what an interesting drug. In fact, the man who invented tamoxifen died last week, Craig Jordan, he was an amazing guy. He was a PhD pharmacologist who invented tamoxifen, and he's like the father of tamoxifen, which has been a drug that's saved a lot of breast cancer lives. But on the side effect side, first, some people get used to tamoxifen and the side effects go away over time. And for other people, when you stop, the side effects go away, although if the side effects are menopause symptoms and you've gone into menopause in the meantime, you will still have your menopause symptoms, but not from tamoxifen. The risky, the serious side effects, the ones, the uterine cancer risk and the blood clot. The blood clot risk goes away in the second year, so no increase after that. And the uterine cancer risk, actually, it's only 0.25% per year, and it goes away also after 2 years. It just doesn't go away like the day you stop, like the other stuff does. It goes away over a couple of years. So these are not permanent, and you can stop them anytime. They're pills, so people do.
Okay, and so in that vein, once you stop, you won't have future effects with the hormone, because there's this worry that if we do something that affects the hormones now, it'll limit what we can do in the future for quality of life or for treatment options.
So I would say that there hasn't been much problem with this, because there are, for treatment, which is, you don't want to, if what you're asking is, if you used like tamoxifen and then had breast cancer, could you use it again, or have you used it up, or would the side effects be worse?
I know there are
that the
some
question?
people who used it as a chemo drug for treatment, not prevention, and then they were unable to do hormone replacement therapy, and I'm unsure if that's because of the cancer or the tamoxifen, and so
Right.
just trying
Okay.
to piece.
Thank you for clarifying the question. So the question was, if you had breast cancer and tamoxifen was part of the treatment, then you couldn't take hormone replacement after your tamoxifen. But the reason for that is you give tamoxifen when the tumor is driven by hormones. So when the tamoxifen is finished, if there are any cells left in the body, presumably they're also driven by hormones, so you don't want to give any hormones just in case. So if the tumors are estrogen receptor positive or progesterone receptor positive, then it's hard to want to give anybody hormonal medication that could stimulate their growth.
Thank you.
Yes. But the question about can you, should we be using tamoxifen more often to try to reduce breast cancer risk for these genes? I think those are very important questions. We have a drug that works, and now we have a way to give it that is acceptable. So I think we have to go back to asking, should we be using more of that? But we'll see. Well, thank you for sticking it out till the bitter end, almost, and now's only one session to go if you're going to be with us.
Thank you, everybody. Thank you, Dr. Garber. Excellent as usual. Please head over to the Grand Ballroom